All right, so welcome everybody to today's talk on this sort of second session of Controversies in Liver Disease. And the purpose of these conferences is to have the fellows discuss a sort of vexing problem that still hasn't been teased out in hepatology and sort of present both sides and we all then come up with a consensus afterwards. So Manny is tackling the issue that we've discussed here in this forum in the past of the risk of HCC recurrence after SVR in the DAA era. So, Manny, thank you.
Hello, good afternoon. So my name is Manny, one of the Transplant Hepatology Fellows. So the topic today is about HCC and DAA. It's a fact or fiction that increase the risk of HCC. So since the introduction of the DAA, the killing hepatitis C has been something of the easy things to do, and there's a more than 90% success for all treated patients. I think most of us will agree that treating hepatitis C will decrease the disease progression, reduce all-cause mortalities, decrease the need for liver transplant, and improve patient quality of life. But still quite a bit of a controversy around the area of HCC and DAA, whether when or who we're going to survey for HCC, whether or not it increased the risk of occurrence or recurrence of the HCC after we eradicated Hep C with DAA therapy. So I'm going to focus mainly on the two debates. So the first one, does the DAA therapy increase the risk of HCC occurrence, meaning new HCC? And the second one, does the DAA therapy increase the risk of recurrent HCC after patient got treated and considered have a very complete response? So, just in general, so the risk of HCC and Hep C cirrhosis is about 2 to 8% per year, depending on the study. In the interferon era, this risk has been much lower after the patient have SVR with interferon. That's like 0.07 to 1.2% is also up to the studies. There's some theory that the immunostimulation and maybe anti-neoplastic effect of interferon has a little protective effect against SCC that DAA doesn't have.
I actually disagree with your second point. I don't think it has been shown that interferon-based therapy reduces the risk because we had so little opportunity to actually cure hepatitis C in anybody who had cirrhosis. So what it shows is that people who had an SVR had a lower risk of HCC, but they also had less cirrhosis. So they had much less risk of HCC, whether they were treated or not. So I don't agree that you have established
none of those people were Child's B or C, or even A minus, because they would crash and burn if we gave them interferon or telaprevir.
Yeah, that's why like when they said the DAA actually have a higher risk of SCC compared to interferon, that's the argument, because like the kind of patient who get treated is different.
Totally.
So the first debate is between the two sides, whether does the DAA increase the risk of HCC occurrence. So the argument said, okay, yes. So what are the evidence that we had so far that they increased the risk of a HCC occurrence? So the first one was the study from Italy that actually created all anxiety and panic in our communities. So it's probably in Journal Hepatology 2016, and that's quite a very heated journal to have a lot of studies in the same area getting published. So this is a retrospective cohort study of 344 patients with Hep C cirrhosis who received DAA. So they followed patients until 24 weeks since the completion of the study with the serial ultrasound and everything. So during the 24 weeks follow-up period, they found that HCC developed in a 26 patients. So overall, it's about 7.6%. When the divided patients have a history of SCC before and those who never have history of SCC, they found that 28.8% of those who have history of SCC have recurrence. So I'm going to put in detail in the second debate when it's just focused on the recurrence. So they found that about 3.2% for the patient who did have SCC, new SCC after the DAA therapy. So they did a multivariate analysis looking at what kind of patient have an increase of having an SCC, and those that do have those have more severe disease, the child classification. The higher the child class, the more likely they will have HCC, which is obvious, and also those have history of SCC or have increased risk of having recurrent SCC with the odds ratio of 12. So they found that the BMI, diabetes, Hep C genotype, and the regimen itself that is not correlated with the HCC occurrence. So these tables are the baseline characteristic of the patient who have HCC and those who did not have HCC. So I highlighted the factor that's significant difference between those who have HCC and those without HCC. So the first one is child class. As you notice, those who have HCC are more likely to be child B. This is also by itself a risk factor for having a HCC. And also they divided patients by using a liver stiffness score between less than 21 and more than 21. And again, those who have HCC are more likely to have a higher stiffness score. The last factor is that if patients have history of previous SCC, they are more likely to have SCC on the follow-up period. And other factors include age, gender, BMI, diabetes, the treatment regimen, and also the whether treatment naive or not naive doesn't make any difference between the two groups. So this is the first study that led to
such a sloppy study.
Yeah, it's a very small study.
It's a small, sloppy study. Big sloppy you could understand. Small sloppy, it's terrible. It's like it's ridiculous.
Yeah.
Patients with HCC get recurrence. It's like, what a shock.
Yes.
Patients with child B cirrhosis get HCC. What a shock.
That's true. And this study have led to a lot more study afterward because of the big.
They should never have published it with that title.
Okay.
I mean, they could have just had an experience, experiential review of the data. But they should not have included patients with HCC beforehand.
Yeah, so true. And then they actually have a separate data on the recurrence too that I will talk about in the second part of the talk. So the second study followed closely by the first study. This also from the Italy as well. So they're even smaller than the previous one. So they do a retrospective study about 54 Hep C cirrhosis patients and all treated with Harvoni for 24 weeks. And they found that this study includes just the patient who did not have history of HCC before. So they found that 4 patients out of 54 have new HCC, 7.4%. So the numerically it looked pretty high during the follow-up period. And the median time from the time of treatment to the development of HCC about 7 months. Due to the small size, they did not see any difference between those who have HCC and those without HCC in terms of age, genotype, child classification, MEL score. This is a table that they presented in the study. The 50 patients without HCC and 4 patients with the HCC. And again, there's no difference in terms of age, RNA, child class, MEL score. But again, the sample size is pretty small, especially for those who have HCC. And they didn't have any detail how they screen patients before the treatment because like some of these HCC might have already been there. So that's pretty much the 2 main study that creating anxiety followed by a lot more study that trying to go
actually the Barcelona presentation at EASL 2017.
Yeah, so
2016 from the Barcelona group was the one that started it. So these were published after that presentation. Also, it was the same big sloppy study. It was 200 patients, but half of them had already had HCC in the past, and they used their control group was the interferon treated group, in the past, which is such a, as Andrea pointed out, such a ridiculous control. Historical controls have problems, but this was a really ridiculous historical control because they were all childs, not A, better than A. Patients.
Yes. So I mentioned that study on the recurrence debate. So what's the argument? What the other study that have shown that DAA doesn't really increase the risk of a new SCC? The first one was a retrospective study on National VA database by Dr. Kanwal and colleague, my former mentor from Baylor. So she looked at the National VA database at about 22,000 VA patients who ever received DAA in the VA system. And looking, the main outcome of interest is the SCC development after the completion of DAA therapy. And the SCC was defined mainly by ICD-9 or the ICD-10 code. Overall SVR in this study is about 86.7%, and 39% have cirrhosis, which again are defined by ICD-9 and IC-10 as well. They've been studied a positive predictive variable about ICD-9 or ICD-10 is about 91 to 93% in terms of cirrhosis diagnosis. So they found 271 cases of SCC during the follow-up period with the incidence of 1.18 per 100 person years, and the median time from the treatment completion to the SCC diagnosis is about 5 months in those who did not have SCC, and those who didn't have SVR, and 6 months in the patient who did not have SVR. So the table 2. This is the incidence of the patient who achieved SVR of 0.9% per year and 3.45 for those who did not achieve SVR. And again, those who achieve SVR probably have a little different demographic of cirrhosis, how advanced the disease is. They did adjust it for age, cirrhosis status, child class, alcohol use, diabetes, beer, and all those things. And the adjusted ratio for those who achieve SVR still have a benefit in terms of decrease the risk of HCC in general with the hazard ratio of 0.28. So this is the Kaplan-Meier curve looking at the economic incidence of SCC between patients who have SVR and those who did not have SVR. And they found that the patient with SVR is associated with 76% decrease in the risk of SCC with the unadjusted about 0.24. And the adjusted one I showed in the previous slide is 0.28. I think this is a very important and interesting graph that they put in their studies. So this is the incidence of SCC in all patients who achieve SVR. So for cirrhotic, the incidence is still 1.82% after they achieve SVR, 0.34% for those who did have cirrhosis. Those are the incidence. So the red line here is the 1% per year, which is a cutoff level for the SCC surrogate that's considered cost-effective by ASLD. So as you can see, like all patients with cirrhotic, they have more than 1%. So that's why we recommend SCC screening still in those who have cirrhosis by achieving SVR. One interesting thing is this group of patients. So they also look at the patient without cirrhosis with different FIB-4 score. And they found those who doesn't have cirrhosis by ICD-9 with the FIB score more than 3.25, which is F3 and above. Still have incidence a little more than 1%. So it's also past the line of cost effectiveness for the SCC screening. So that's why most of us will continue to do SCC screening in those who have advanced fibrosis even after they achieve SVR. So this
Can I criticize that study a bit?
Okay.
Can you go back to the time? Yeah. So next, First, I think that next slide.
Okay.
From what we know about the doubling time of HCCs, it's very likely that many of the HCCs that were diagnosed within the first 8 to 9 months actually were pre-existing. There's evidence that if you have HCC, you're much more likely to fail therapy. So the non-SVR group is automatically enriched for people undiagnosed prior HCC. This is a real-world study. We know in real-world studies of DAA, cirrhotics are more likely to fail therapy. So you enrich your non-SVR group for people who have cirrhosis, who have risk for HCC. So I do not believe that this study shows that having an SVR decreases the risk.
Even though they adjusted for cirrhosis status?
Right, because they didn't. First of all, there's not evidence that the people who had an SVR were screened as religiously as the people who did not have an SVR. It's much more likely that people who failed therapy continue to be in care and undergo screening. So the chance to diagnose an HCC was much greater. And also, because of the time course, we know from what we know about the doubling time of tumors that many of the tumors pre-existed.
Possible, yes, because it's like very short, like 5 or
Yeah,
like 6 months.
absolutely. So probably what they're picking up is a combination of the fact that if you have a pre-existing undiagnosed tumor, you're more likely to fail therapy. If you have cirrhosis, you're more likely to fail therapy. And you probably don't have equal HCC monitoring in the people who fail therapy and the people who don't. And all those things are going to make a graph that looks like this.
Yeah, that's a very good point.
Andrea, why does having HCC lower the risk of responding to therapy?
Well, it's an observation, and I would say quite a robust one. Doug has commented on it a number of times. The best explanation I can give is, first, we know if you sequence HCC in tumors, it has a different sequence than HCC that's not in tumors.
HCV.
Sorry, HCV, yeah. The virus is different in tumors, and it seems to replicate more slowly, and the drugs actually only act on replicating Hep C. So the tumor HCV may be less susceptible, and there's always the possibility that you have poorer penetration. We don't know much about how the drugs percolate throughout. It's possible they just don't, like it's an oral drug. If first pass is the typical way that it gets into a hepatocyte, then that's going to be the portal blood from the intestine, and we know that
not the arterial blood that goes through.
Yeah, so they may get less drug, and they may have a drug-resistant variant.
It's about 76% SDR, actually, in real world data, compared to 96 or 90% people without HCC. Andrea mentioned the reasons why. So, but we're not sure. Those are the HCCs we know about. So these are maybe the ones we don't know about. So it may not be the same thing. But we've actually, the only time we've ever seen late relapses after 24 weeks have been in people with HCCs. So the virus was probably hiding there in the HCC where the drug couldn't get to it. And then eventually it popped out to the surface and reinfected.
Okay. So the second one is also another VA study, but this one they included the interferon era into the study as well. So this is again using National VA database, about 60,000 patients. So they include 35,000 for interferon era, for 4,500 for interferon plus the DAA, and 21,000 for DAA only therapy. And the SVR is over here, so as you probably can imagine, the DAA therapy is much more effective. So they excluded the patient with SCC prior to the treatment. Again, they used the ICD-9. Patients have less than 180 days follow-up. Those have history of SCC diagnosis within 180 days from the treatment start date. And in this study, 16% have cirrhosis and 5% have a decompensated cirrhosis. And they found 2,200 patients with the SCC during the follow-up time.
Wow, that's a lot.
Yeah, from 60,000. So, so this is the table. I indicated the incidence of SCC in different subgroups. So in general, so the risk of SCC in patients of cirrhotic is 1.97 per year. And for non-cirrhotic is 0.04. When they divide into a different regimen, so interferon at 0.28% per year, DA plus interferon 0.6% per year, and for DA only is 0.92% per year. This one they adjusted for like confounder like a cirrhosis status and other things. And after they adjusted, the rate that looked kind of a little higher in DA therapy actually did not be significant difference between each regimen. So these are adjusted the ratio 0.32, 0.45, and 0.29 here. Again, so they said this is the SC. So the green one is a cirrhotic with no SVR. This one is cirrhotic with SVR, non-cirrhotic without SVR, and non-cirrhotic with SVR. So the trend is the same in our treatment regimen, and overall that those who have cirrhosis without SVR have a higher risk of SCC, and going down to the least would be non-cirrhotic with the SVR, which is pretty obvious.
can you go back a little bit? So I think one of the advantages of the interferon group, which remarkably is a pretty similar number to the DA group in such a short amount of time.
Yeah.
She's showing that the DA was really treating a lot of patients. But you'd expect that because of the number of years that have elapsed since the interferon treatments, you're going to have a lot more ability to capture, HCCs from in terms of occurring, whereas your follow-up is really quite short in DDAs.
Yeah, that's one of the arguments that interferon for DA it's probably not going to like 1 or 2 years max. So DA can, like for the interferon would be like 5 years and more for the follow-up time in this study. Yeah, the short follow-up will lead to a little less pickup on the HCC.
Right, so then it would underestimate the number of HCCs that would occur after DA therapy. You'd expect that.
Yeah, that's possible. Okay, so this one is again the same thing for the SCC surveillance. They're divided into each the era and different regimen in patients with cirrhotic, without cirrhotic, short-term short follow-up and other things. And they also adjusted for all the age, comorbidities, cirrhosis, alcohol, drug use, and other things. And again, they did not find any significant association between a treatment regimen and the risk of SCC after adjusting for the confounder. So the author concluded that it doesn't matter what the regimen that you got, if you achieve SVR, or the risk of SCC is the same. So they kind of argue that DAA doesn't really increase the HCC incident. So this is the third one is a meta-analysis, again comparing interferon and a DAA. So it's a meta-analysis of a 26 study, including 7 interferon and 9 DAA. And the number of patients in the total of the whole meta-analysis is 11,000 patients. This is just for the occurrence. I will mention about the recurrence later on. So So they found that in the DA studies, patients were a little older, and also they are more likely to be genotype 1 compared to other genotypes in the interferon therapy. They were more likely to be other child class like B or C, interferon 100% child class A. And also the follow-up time, as Dr. Im has mentioned, is only an average of 1 year for the DA study, and 5.5 years for the interferon studies. And they found that the SCC rate is about 2.9 per 100 person year in the DA study and 1.1 in the interferon study. So numerically it looked higher, but as you imagine, the patient population are different between the interferon and DAA. So this is as far as looking at the cumulative incidence of the SCC in the interferon therapy on the left and the DAA on the right. And they found that the incidence 1.14 in the interferon group and 2.96 in the DA study. But just to note that the DA study is like very heterogeneous, like it was like all over the place. And the I-square is 80%, so not sure how much they're going to be. And they found on the univariates, when they're looking at the SCC occurrence between studies, they found that the average follow-up year and the age of the patient might influence the result in terms of SCC in general. So they are doing a multi-variant analysis including these 2 factors as the adjustment. And they found that when they adjust this for age in the follow-up year, there's no difference in terms of SCC incidence in those who receive DAA and interferon therapy. So again, it's the same conclusion that with the previous study, that the treatment regimen doesn't affect the SCC occurrence rate. So in conclusion for the first debate about whether or not does the DAA increase the risk of SCC, so I mean, numerically, it looked like the patient who received DA have a higher annual incidence for SCC, but as you can imagine, those who received DA seeker have higher ML, they're like more child class B and C. They're harder to treat. So by those risk factor itself for the SCC, so you can imagine the incidence will be higher. And as previous study have shown that after we adjusted for those confounders, there didn't seem to be any difference, like any association between the treatment regimen and the HCC incidence itself. So I think, personal opinion, I don't think DA increased the risk of a new HCC. It's just the treatment group are different.
Are there any mechanisms associated with conservation? Molecular mechanisms of insulation?
Yeah, so that's one like theory that because I mentioned later on, like the DAA causing an abrupt decline in the Hep C viral load, and so the immune system, before they have information because of Hep C present, when it dropped very quickly, the immune system kind of shut down, and what they shut down with it is the immune surveillance for the tumor, so that leads to the increased SCC risk after the treatment. That people talk more about it when it's recur, but they explain that the same thing might explain the SCC, new SCC after DA as well. So moving on to a second debate. So this is about, does the DA increase risk of the SCC recurrence after patient have a complete treatment? So Superman said yes. So what are the evidence? So the first one is a study from Spain. So
This is the Barcelona.
There's a Barcelona one. Yeah. Yeah, they published in the same issue at the Italian study, and that general hepatology issue is
bigger and sloppier.
Yeah. So they included 58 patients who have Hep C infection and a history of SCC that were previously treated with either in the IFA resection or test, and they have confirmed complete radiological response before the start of the DA therapy. So they exclude patients who before treatment have a non-characterized nodule, meaning tumor a little less than 1 centimeter that we don't know what it is. They exclude that from their study. And everybody received DAA with the SVR of 97%. So this is a basic characteristic of the whole cohort. 58 patients. Majority of the patients have cirrhosis, 94%. Most of them have child class A. And in terms of SCC treatment, 50% have ablation, 34% resection, and 10% test. So before the treatment, before the DA therapy, they did the CT or MRI in all patients who have history of SCC just to make sure they have a complete response before they start. But afterward, they actually use ultrasound for SCC surveillance. So they found the median follow-up time after the DA start date to the time of the SCC recurrence is about 5.7 months, and 16 of the patients have virologic tumor recurrence, about 27%, with a median time from the DA start date to a recurrence of 3.5 months. So it's very short from the start time to a recurrence. Like some of them even just like less than a month after the treatment end. So the median time from the SCC treatment from the start time of the DA therapy is about a year. And then the median time from the last visual response to the start time is about 1.7 months. So they won't wait that long. Okay, you're free of treatment, let's start. So these are the 16 patients who have a recurrence in these studies. So most of them recur within Milan criteria, except for these 4 that underline here. So they either multinodular or came out as an infiltrated tumor with the extrahepatic in 2 of them. So this study, the order was like, okay, the recurrence is like 28%, and a lot of them were pretty aggressive. Before they seemed like they're not a very aggressive tumor. So there is a question whether the DA therapy making the recurrence more like frequent, and whether it's more aggressive too.
What is the expected recurrence rate?
It is actually about 25 to 30% for the. Which is actually that's why I think the numerical actually doesn't seem that much different.
The 6 months recurrence rate is 15%. After resection.
Yeah, I'd expect it to be lower than what they found. Right?
Mm-hmm.
So,
They found 30, and the expected is 15.
so they're using historical controls.
Yeah.
Well, they used the patients for the Biostorm trial. So for the Biostorm, it's patients resected, randomized to placebo or sorafenib to prevent recurrence. So they took the placebo arm, and they estimated the recurrence rate in these patients resected, and it was 1%.
The other thing is, like, if you look at patient number 8, for example, like patient has infiltrative HCC on sorafenib and got ablation, but then the patient is not cured; it already has ongoing cancer. So I don't know why they call that.
No, that is after. It's recurrent. Yeah. So the initial one is actually one tumor, and they got ablation, but they recur as an infiltrative tumor with the extrahepatic metastasis.
They have to have negative scans as part of the inclusion criteria.
Yeah, but look at their AFPs at the time of starting DAAs.
Like this one in
360,
particular.
66, 38, 91.
And the other thing is, if you want to say somebody is really cured, you really need to have a good scan. You know, if you're not just gonna do, I don't know if they talked about the scans they did, for example.
They did the CT or MRI before the start, but after that they used ultrasound for screening.
I'm not sure about that.
I think they
I
did.
don't think so. I think they must have done a CT scan or MRI to confirm that there is no residual tumor.
Oh yes, they use a CT before, but on the surveillance after the DA therapy, they use ultrasound, and if they found no nodule, they use a CT or MRI
No,
to
but
confirm.
we're talking about the time. So the question refers to, are we including patients that already have HCC despite being resected? So for that, the time between treatment and inclusion and starting the DA was almost 1 year.
Most 1 year.
We have 1 year of the patients without anything. And during that time is when you do the CT or the MRI to confirm that there is no.
Yeah, they did CT to MRI. Yes, they did CT to MRI.
It makes me wonder though, because of these AFPs, you know.
I mean, it's a short study. The AFPs are, some of them are high, but I'm sure there are also resections with AFP of 200 that did not occur.
Yeah, Dr. Scanner?
The issue of the AFP is an important one. You know, just from our treating these people with DAAs, if they have elevated AFPs, and if their virus goes away, you know, all the AFPs are coming down, and they never go up. So I mean, I think we would follow these AFPs in serial fashion with patients. If you're on treatment, your viral load is coming down or goes away, and your AFP is going up. For me, that is clear evidence that there may be HCC that's still there. It would be interesting to know what the status of the AFP was, you know, during this time, not from the beginning and at the end.
Yeah, no, they didn't mention like what the AFP is like during a therapy. So that's the first study. So this is a study that I mentioned before, the Italian study, but it's probably just for the recurrence. So again, 244 patients, 59 of these have history of SCC that were previously treated. 1 out of 59 were outside Milan already, but before even start therapy. So they found a median interval between the SCC treatment and the DA therapies, again, is about 1 year. And all patients did not have any active SCC at the time of the DA start date, and they said they use CT or MRI for in terms of the surveillance. They found a multivariate analysis that the age, liver stiffness were associated with the SCC recurrence. Interestingly, the younger the age, the higher the risk in this study. And as you expect, more liver stiffness also associated with SCC recurrence. They did not see any association with the genotype, DNA therapy, or the type of treatment that they used for the previous SCC in terms of SCC recurrence rate. So this is a demographic study between patients with SCC and without SCC in terms of recurrence. So patients who have SCC recurrence seem to be younger. They more likely to have a higher liver stiffness score, but there's no difference in terms of genotype or whether or not they receive IFA or surgical resection or test. There's no difference between the current treatment modalities. So again, the number they quoted here about like 27% also, and they said the number is high for the recurrence SCC, and they mentioned that this might be an issue of increased SCC recurrence after the DA therapy. So now come to the other side of the debate. whether or not it's actually increased the risk of SCC. So this is the French study. They also published in the same journal of hepatology with the other two from Italy and from Spain. So this is the cumulative data from 3 French prospective cohort study that they were doing in patients who received DAA, and they get some data from this cohort. So including there are 3 cohort. The first one is hepatitis cohort. So the main reason to do this cohort for them is to look at the real world data for the effectiveness, but they included patients who didn't receive treatment also, and they get some of that patient to look at the HCC recurrence. So the hepatitis cohort have 267 patients who have hep C that were treated with HCC before. 189 received DAA, and the 78 did not receive any treatment, and they used that as a control. For the server cohort, this is the study that they used to study national history of patients with cirrhosis to see what happened with their complication, SCC, and whatnot. And they found 79 patients who have biopsy-proven hep C cirrhosis who received treatment for HCC, and then later on received treatment with DAA, which is 13 of them, and 66 didn't receive any treatment, and they used that as a control. And the last one would be a complete cohort that they used to follow patients after transplant with the hep C. And among that, they found 314. They were transplant patients who were transplanted for SCC as an indication. And then after transplant, received DAA for treatment, and they look at how many of these transplant patients have a SCC recurrence. So this is a demographic for the whole studies. So the hepatitis study, so patients who received DAA is a little younger compared to those who did not receive treatment. The rate of cirrhosis in each arm is about 80% for DAA, 72% for the non-treatment control. The recurrent rate is 12.7% in the DAA group and 20.5% in a non-treated group. Going into incidence is 0.73 per 100 person months for those who received treatment, and 0.66 for those who did not receive treatment for the recurrent rate. For the servers study, so the SCC recurrent rate is 7.7% compared to those 47% who did not receive treatment, with the incidence of 1.11 in the treatment group and 1.7. In a non-treatment group. So for each cohort in just a bit. So the first one is the hepatitis cohort. So they have a median follow-up of 20 months after the DAA initiation, and for the DAA group, and about 26 months for the untreated or control group. They found that after adjusted for confounders, the hazard ratio for SCC recurrence in the patient who received DAA is 1.09, and that did not reach statistical significance. So they're saying that DAA doesn't increase the risk of a SCC recurrence in this cohort. And they didn't find any increase in SCC recurrence in the first 3 months of treatment. Also not in the after that, like 6 months after the treatment. So there's no increased rate of SCC recurrence even in the first 3 months and even in a longer follow-up. So well, conclusion from the hepatitis cohort is that DA doesn't increase the recurrent rate for the SCC in those who previously treated and confirmed surgical response. So the severe cohort is again 79 patients who received SCC in remission, and then they received DA afterward. Again, they after adjusted for the confounder, the hazard ratio for SCC recurrence in patients who received DAA 0.41, and again, this not reach statistical significance. So they also conclude that even from this cohort, for those who confirmed hep C cirrhosis of SCC got treated, there's no increased risk of SCC recurrence in a DAA group compared to a control. For the transplant patient, they don't have the control, so it's just more like a descriptive studies. So they found 7 patients who have SCC recurrence. But they mentioned that those have recurrence, 5 of them already have predictive factors of recurrence on the explant. So they have multinodular, they have microvascular invasion. So 5 of them have predictor by themselves that they might have an increased, like high risk of recurrence. So because there's no control, or cannot tell for sure whether like DA increase or not increase, but they did not think that by DA itself increase the risk of tumor recurrence after the transplant, because already have risk factor by the explant itself. So this is the meta-analysis I mentioned earlier about the occurrence. So this part, they looked at the recurrence of a HCC. So they include 7 studies that looking in the HCC recurrence, including 7 studies with interferons and 10 study with the DAA. And they found the recurrence total is the total number of patients in the meta-analysis is 2,000 patients. So this is the demographic between the 2 studies. So the DAA, they're actually a little younger for the recurrence that were included, 64 compared to 66. Again, more genotype 1 for the DAA and other genotype for the interferons. They found, again, follow-up period is shorter, like 1.3 years for the interferons, and for the DAA, and 5 years for the interferons. And they found the recurrent rate is 12.1% per year for the DAA group and 9.2 for the interferons group. From the number, it looks a teeny bit higher, but it actually doesn't seem much different from the number that you mentioned, like 15%. Doesn't seem alarming in terms of number. So this is again forest graph comparing all studies for the recurrence rate for the interferon group, and they found incident 9.21% per year for interferons and 12.16 for the DAA therapy. Again, the DAA study also very heterogeneous as well, with the I-square of 89%. Both very actually, like interestingly, I-square like 0% for the interferons. They're quite homogeneous here. So they again adjusting for the follow-up periods and age of the patient that seem to be significant in a universe analysis. So when they adjust that with the age of follow-up time between the DAA and the interferons, they did not find any significant difference in terms of HCC recurrence between the interferon and DAA treatment, with the rate of 0.62. So in this meta-analysis, they concluded that regardless of the regimen, DAA didn't really increase the risk of HCC recurrent. So in summary for the second debate, so as I mentioned as an answer, that is hypothesized that the rapid decline of Hep C DNA had led to a decrease in the immune response in the body, and part of it might decrease the immune surveillance of the tumor. So those patients who were treated with SCC and maybe have a little tumor cell left but not obvious, starting to flare after with the recurrence in the early time after DA treatment. So most of the studies that show a high risk of SCC recurrence were more like small, like observational studies. There's no control to compare with. When the French study was prospective study, they have a control and did not show any difference, and meta-analysis did not show any difference in terms of recurrence between a group. Still, some experts still say, well, let's wait for 6 months after the patient have a complete residual response to see how they goes in terms of tumor biology before it's decided to start DAA. I think that was like more like an open discussion. What do you think about waiting like 3 or 6 months, see how they're doing before starting the DA therapy?
Yeah, some people at other medical centers do that. I polled my colleagues around the country. About half do. Our people, our hepatobiliary guys, are very anxious to get the patients treated, actually, like immediately, even during their HCC therapy, because they really feel like it will reduce recurrence rates. So far, we've been lucky. We've had a much higher SVR rate than the published ones of 76%. So, because that's the argument. Wait till the tumor's gone, and then there's no tumor to harbor the virus, and then you can go ahead and treat after the healing is all done. Whereas, Myron and company feel like if we can get rid of the virus, we can also stop the other oncogenic mechanisms that are happening elsewhere in the liver, not just in that one particular tumor that's already occurred.
Actually, with the short term of DAs before the section, actually the procedure seems to be easier.
Well, it reduces the inflammation dramatically, within a month or, within a very short period of time, because the ALT and AST normalizes within a couple of weeks or a month sometimes, actually, so it'll make their job easier. Yeah.
I know that in Barcelona, that they don't treat patients. I mean, if you have an HCC, you get a resection, and you have hepatitis C, they're not treated with it. There's a big debate about the ASLD. Was that
they can prove that there's higher recurrence rate that way, or higher recurrence
No, because
rate.
they're not treated. So they cannot assign that to leukemia.
Yeah, that's
I think it's a little bit brutal, but it's their protocol.
Is that a cost effect? I mean, do they just say the risk of recurrence is so high that you don't get the benefit from treating?
So talking with them, more than the risk of recurrence, is the type of recurrence that these patients are getting. So in the paper that you mentioned, one thing that they highlighted is that the recurrence that they get is
Terrible.
it's very aggressive, it's very advanced. You know that you get a second nodule of 2 centimeters, you're going to ablate again, and that's it. So that's what forced them to say, okay, let's hold it because we don't want to see, patients with exploding tumors.
Yeah, interesting.
But it's true that hardly anybody has reproduced that experience
The
of,
bad-looking one.
of the DAAs inducing, aggressive tumors in patients with small HCC, very well staged, and very clear that it's a best case.
Yeah, we have not seen that here at all.
So, Busu, in this clinical scenario, has there been any studies to look at liquid biopsy or gene signatures to see, other than just there was a pre-existing HCC that just wasn't detected that is now blossoming, other sort of high-risk features that may suggest, because these numbers are small enough that you could see randomness causing problems, and that's part of why you have to have bigger studies. But
I don't know. I think there's few data to say, but I think the recommendation of not treating with DAAs is, I think, it's too much.
Yeah.
Coming from Barcelona, I know
That would not work in the U.S.
I mean, there was a guy in the ASLD that actually said that would be considered unethical.
It would, yeah. It would be very good for the trial lawyers.
Yeah, I'm thinking actually we did a lot of treatment, and there must have been SCC patients including there. There haven't been any VA study that looking into this before. I'm sure there's a lot of patients that they treated. All right, so just a little touch. So this I mentioned before about the SCC surveillance after the SVR. So as I show in the VA studies and also in meta-analysis, those who have cirrhosis or advanced fibrosis, even after SVR, they still have a SCC incident more than 1% per year. This is more than what the SLD recommended for cost effectiveness for SCC surveillance. So again, it's still recommended in those patients that they should continue SCC surveillance. For those who have less than that, like a F2, F1, I mean, they still have risk of SCC, but it just doesn't reach the cost effectiveness like cutoff yet.